Well, good morning, everyone. My name is Dr. Anand Parikh. I'm the Chief Medical Advisor here at the Bipartisan Policy Center. I want to welcome all of you to today's event. For the next 2.5 hours, we're excited to focus on patient-centered comparative effectiveness research and its impact on the provision of healthcare services and on health outcomes. 2 years ago, BPC hosted a series on this topic which aimed to provide policymakers with a better understanding of what this research was all about. We learned a couple of things from that series. Number one, comparative effectiveness research matters to patients, healthcare providers, health systems, and payers. Number two, effective dissemination of results is a major barrier to translating findings into practice. And number three, shared decision-making tools are critical to incorporating comparative effectiveness research findings into doctor-patient conversations. While there's in general bipartisan support for medical research in the form of laboratory research or basic science research, and even traditional clinical research, less is understood about the importance of patient-centered comparative effectiveness research. From my perspective, as a former clinician as well as public servant, government does have a role to play in supporting this research within the private and public sectors. While there are many clinical interventions out there that have been deemed safe and effective by the FDA and are now paid for by public and private payers, there's a paucity of comparative effectiveness research on which of these interventions work and for which populations. In addition, too often, research does not include patient input and patient involvement. Many experts believe that much of our $3.5 trillion healthcare system today goes to what is called low-value care, or care that doesn't demonstrably lead to better health outcomes. Comparative effectiveness research is an important tool to ensure patients are directed towards not just services that are safe and effective, that's not good enough, but services that might be better for them compared to other ones out there. And healthcare providers and payers are right there behind patients in their interest. We're pleased today to showcase several panels of experts from across the patient and clinical community to discuss recent applications of comparative effectiveness research and future investments. This topic is timely, given that the authorization of the Patient-Centered Outcomes Research Institute, or PCORI, created by Congress back in 2010, expires at the end of this fiscal year. Accordingly, our first panel will focus on updates from the Hill with key professional staff. This will be followed by a second panel, which will showcase two specific patient-centered projects so that stakeholders understand how this research is conducted and why it's important. Finally, a third panel will discuss the dissemination and translation of specific patient-centered outcomes research which impact care delivery and accelerate systems change. So with that, I'd like to now introduce Bill Hoagland, BPC's Senior Vice President, who oversees both our health as well as our economic programs, and invite him to come to the stage along with the first panel. I think most of all of you know Bill, but he's been a distinguished leader on health and budget issues, both in the private sector and on Capitol Hill and the Congressional Budget Office, spanning many decades. Lastly, a few housekeeping notes. This event is being streamed live via webcast. Welcome to everyone, and thanks to everyone who's joined here, of course, in person today. We'll have an opportunity for audience Q&A after each panel, so just look out for the roaming mics. So without further ado, Bill and panel one. Thank you.
Good morning, everyone. Welcome. Send my welcomes also to all of you for being here. And first of all, congratulations to all you Cavalier fans out there. I didn't go to UVA, but my money and my daughter went there for a long time, so I am loyal to them. Those of you who stayed up late last night and watched it, it was quite an ending. First of all, welcome to this discussion about comparative effectiveness research and its application, and with, as Anand had said, a particular focus on PCORI and where it's going. First of all, welcome to our two guests from Capitol Hill, Senate side. I spent a long time on the Senate side, so I'm very familiar with what staffers have to go through, and I appreciate you taking the time to come down here while we're in session today. To my immediate left, Maura Fitzsimmons. She's with the Senate Finance Committee. Senator Wyden, ranking member, serves on that particular committee. She has been there since 2017, and before that at HHS. And to her immediate left is Alyssa Did I say it right? Did I listen? Thank you. She's a legislative assistant to Senator Chris Van Hollen, great senator from Maryland, former congressman, and as an old budgeteer myself, having worked with Senator Van Hollen. In fact, dare I say this, Senator Van Hollen was a staffer at one time when I was a staffer. It shows you how long it's been, I guess. I don't know. So he's on appropriations. He's on the Banking Committee, appropriately. He's on the Senate Budget Committee, and he's on Environment and Public Works Committee, I believe. So thank you both for taking the time to come down here and discuss with us the legislative outlook. Just a little bit of quick background. As Anand had said, this is the third public event that we've had here at BPC as it relates to focusing on comparative effectiveness research. And I think most importantly for old budgeteers particularly, the real issue in healthcare is cost, the cost of healthcare. You all know the statistics, rather startling in some ways. 18% of GDP, 1 out of every $5 is spent on healthcare in this country. I was struck by another factoid that I came across over giving another talk earlier this last week, that the United States is 4% of the population worldwide, and yet we're 40% of all global healthcare spending. And so the question might be asked, what do we get for that expenditure going forward? If you believe the recent statistics, 3 years less on standing on Earth with the decline. But more importantly, the American Journal of American Medical Association last year compared healthcare across 11 rich countries and found that the U.S. came in last on life expectancy and infant mortality. So this issue of how we are expending these dollars, how they're effectively being spent, is critical, it seems to me, to the healthcare policy, the development of healthcare policy. Well, before they arrived in the Senate back in 2010, of course, there was 9 years ago, the Patients Protection Affordable Care Act was adopted that established the Patient-Centered Outcome Research Institute. And that specific legislation, as Anand said, authorized the creation of PCORI. And let me just read what I understand, what the legislation says, rather long. It's to assist patients, clinicians, purchasers, and policymakers in making informed health decisions by advancing the quality and relevance of evidence concerning the manner in which disease, disorder, and other conditions can effectively and appropriately be prevented, diagnosed, treated, monitored, managed through research and evidence systems. Wow, a lot put on this organization. So also that legislation in 2010 appropriated $1.26 billion, effectively $150 million a year. That's been appropriated. It hasn't had to go through the budget appropriation annual. It's been there. It's been there from the beginning, and that, as Anand says, running up. Also, besides the $150 million that annually. The trust fund that funds the PCORI, as I understand, receives about $137 million from the Health Insurance Trust Fund, and then also the fees that are paid, that $2 per insurance coverage out there on each carrier out there, and brings it about another $350 million. So the total operation of PCORI is about the fund is 600, and then of that 600, about 80% of it remains with PCORI. The other 20% goes back to ARC and HHS. So this brings us to the question, the big question, and now ask our fine panelists to how's this going to play out in terms of the reauthorization this year coming up? And let me be very clear. This was part of the Affordable Care Act, so it was embedded within the Affordable Care Act when it passed. Now it could be out there standing on its own, or how will we approach this? Mara, why don't you're the Finance Committee, you have jurisdiction over this. How's it going to play out?
So obviously there's not the Affordable Care Act vehicle to attach PCORI reauthorization to, but that being said, there are a number of other Medicare and Medicaid policies that need to be extended at the end of this fiscal year. And so similar to previous years, we anticipate having an extenders package, which I envision PCORI would be attached to that larger package. It's very rare that we have standalone healthcare bills moving independently these days, and so I think this would follow the same course as previous years, where a various assortment of policies that need to be extended or authorized for the first time are kind of glommed together into one larger package.
Mm-hmm. All right, Alyssa.
Yeah, so I mean, I guess to just sort of speak from the PCORI specific reauthorization perspective, Senator Van Hollen, along with Senators Warner, Cassidy, and Capito, are very excited to lead the PCORI reauthorization this year. We are in the very beginning stages of soliciting feedback from various stakeholders on what they want to see as part of the PCORI reauthorization to help sort of inform what a reauthorization bill will look like. And I think it's become very clear to us that there is very broad support for PCORI and the work that they do, and a lot of excitement around reauthorizing.
So in the big picture then, we're looking at some other instrument that's going to pull PCORI through again. Is the extenders package maybe? Is the way you're thinking this is going to play out?
That's how I envision it, just thinking through the legislative timeline for the rest of the year. I imagine it will be a larger vehicle that there are a number of different members' priorities are attached to. And so
there are such things as appropriations, continuing resolutions maybe, or raising the caps on the current law. Also here at BPC, we make wearing another responsibility I have here, we have an estimate that what we call the X date, the date in which the federal government will default because of the statutory debt limit runs out. We're looking at that sometime along the end of September, early October, so it seems like a perfect storm developing here around, and we've been through this before, but then this you're thinking maybe if not on extenders, there's a bigger set of issues that Congress is going to have to deal with at the end of the year, so that it might be considered within that package too, right?
So I think you're very correct in that there are a number of different pressing deadlines that we have to deal with this year. And being in the minority, we don't have as much control over the agenda, but certainly are looking forward to having a lot of bipartisan conversations with my counterparts on the Finance Committee about what the extenders package what shape it might take.
You're in the minority, but my recollection, it usually takes 60 votes to pass anything in the United States Senate, so you still have some leverage there.
That is very true. That's why I'm very grateful that we're coming from a very bipartisan point this Congress, where the committee's done a lot of bipartisan work. We're actually having a bipartisan hearing this morning, and so I think we're starting from a very good part in terms of having those conversations.
And not that you need... Where's the House? Do you have any sense where the House is on this issue?
So at this point, there's definitely interest in the House for reauthorizing PCORI. I think that they're not quite as far along in the process in terms of soliciting stakeholder feedback and putting together a bill.
And going back to wearing my budget hat for a second, and this reauthorization then you would envision would be a continuation of the automatic appropriation as well as the fees and the transfers, that you would envision the same kind, at least in what you're discussing right now in the same kind of mechanism?
Yeah, so at this point, like I said, we're still sort of in the process of soliciting feedback. We have not heard feedback from any of the stakeholders that they would like to see changes in the financing structure of PCORI.
That's that leads me to a kind of a question about stakeholders out there. I think I mentioned to you earlier that there's a book on healthy politics, And citing a study from UC Berkeley School of Public Health, the authors state, I quote, patient advocacy groups and researchers have tended, this may get into the later panels and I apologize, but patient advocacy groups and researchers have tended to mobilize within rather than across disease categories, limiting their organizational cohesion and impact in the broader debates over the future of comparative effectiveness research. Do you think patient advocacy groups are supportive, or are there patient advocacy groups that are not supportive out there? Where's the advocacy community on this issue?
Patient groups supportive of reauthorizing PCORI? Yes. I mean, based on the stakeholder conversations that we've had with patient groups, they're very supportive of seeing PCORI reauthorized and see a lot of value in the work that they do. And I think it's also important to to note why PCORI, the research that PCORI does, is different than the research that you're seeing from NIH and AHRQ and DoD. That all provides significant value, but PCORI is very unique in its patient-centeredness and the fact that patients are engaged from the very beginning of the research process throughout it. And that's something that has been, I think, a very welcome change for patient groups because they are, for the first time, seeing that direct engagement with researchers, and I think that the response from the research community has been very positive too, in that it sort of helped shift the culture of how researchers approach the type of research that they do, and incorporating patients' viewpoints and their needs and their desires in terms of what they want to get out of research and comparative effectiveness research that helps them make better decisions about their health care.
Okay. Yeah.
Yep, I would certainly echo what Alyssa said. First of all, I very much appreciate her boss, Senator Van Hollen, being a champion of PCORI reauthorization. And I know Alyssa, as part of that effort, has done an incredible amount of outreach to stakeholders. But in the meetings I've had as well with some of the same groups, they have really shown a great deal of support for reauthorization. And we certainly, hearing that feedback, want to move forward to be able to provide PCORI with sustainable funding to be able to fund these multi-year projects that really do change the culture of the way research is conducted.
I have to ask you, Maria, I hear who the champions are that you mentioned. Is Chairman Grassley supportive also, or do you know?
So I actually can't speak for Chairman Grassley's position today. Senator Wyden certainly is, and I hope to, as I mentioned earlier, continue those discussions with Senator Grassley's team. I think they're willing to engage in those stakeholder discussions, but certainly can't speak to their position.
I understand. And talking about stakeholders, patient advocacy groups, but I'm going back to the budget just a second again. About $350 million of funding that comes into the trust fund is coming in from those fees on insurance coverage. Are those stakeholders with you?
So the plans that we have talked to are generally supportive of reauthorizing PCORI.
Yeah, good.
So I mean, there is some feedback that they've provided in terms of changes that they would like to see, and that's something that we're entertaining all of that feedback as well.
I want to leave time for questions from the audience here, but I just want to, since you mentioned a number of other areas, I'm also, and this is Anand's area, so I be careful what I say about this, but I'm struck by the fact that if I believe the numbers on this, we spend $3.6 trillion, that's both public and private in this country, on health care. And when I look at what might be called public health, and I consider this to be kind of in that vein, less than 3% of all spending in this country goes to public health. $100 billion out of the 3.6, amazing. And yet, in the present budget, and now I'm getting in trouble here wearing my red tie and all that, I'm sure, with the Republicans, but when I look at the president's budget, HRSA has cut $1 billion, CDC down 1.3, NIH down, particularly in your area of the country, in Maryland, 4.5, SAMHSA down $650 million, ARC, even with the $450 million down. There is a need for this type of program, and I strongly assume that as we go through the budget this year and go through this, you'll be part of a bigger discussion about where we should be investing our dollars going forward. 8 minutes left here. Unless there are any further comments you want to risk yourselves to the audience out here. And any questions? We have microphones coming around. Just please introduce yourself and any questions you have. I thought I saw one back there. If not, I can keep asking questions up here. They won't like it if I do this. Okay, let's talk a little bit about PCORI's budget then. 2019. When I look at it, it's about the current budget, about $630 million. If I understand, about 84% of that goes to research, and only about 3 or 4% of it goes for dissemination and implementation of findings. It would seem after 10 years that the balance should be a little different. When you're talking about reauthorization, will you be getting into how PCORI's dollars are being allocated or not?
I don't know that it would be to that granular of a level. I mean, I think on the dissemination, I will say that what we've heard from the provider groups, so clinicians, that that a lot of this research is potentially has a lot of value for, that the physician groups do some of their own dissemination as well to make sure that they're pushing out PCORI's findings in a way that's useful to various specialties.
Okay. Right. Go ahead, Anna, because I got one here that I have to ask, but go.
I was just going to ask Alyssa more if you can comment on, it's been 10 years since PCORI was established, and obviously there's a lot of staff turnover on the Hill. To what extent is there a need for just staff education about PCORI, and how much does that impact as you begin these bipartisan discussions, just educating staffers and members, and even members? A lot of members are new as well. So talk a little bit about the education on the Hill itself about this topic. That'd be great.
Yeah, this has been one of the issues that we know that we're currently facing, and we know we're gonna continue to face, is sort of that education curve on what PCORI is and what they do, and to the point I made earlier, why what they do is different. And so that's something that we've been working with some of the outside groups. There have been a number of briefings PCORI has done up on the Hill to not only educate staff about what PCORI is, but also to educate staff about some of the research that they've done. That I think is very impactful on a lot of issues that members and staff care about. And then this year, we are still in the midst of our big appropriations fly-in season, and there have been a number of groups that have been up lobbying in support of reauthorizing PCORI. So that's been another great sort of educational opportunity for staff and members to actually hear from constituents with various organizations that are supportive of reauthorizing PCORI.
Right, I absolutely agree. I think just with the amount of healthcare news that's been coming out in the last couple of years, PCORI, since it hasn't had to be reauthorized since it was first authorized, hasn't been the most prominent issue. But I think the more that staff and members hear about the research that's going on in their respective states, I think that's a really helpful tool to be able to show just the impact that it's having, and not only on the broader research community, but on the member-specific district or state as well.
On Sarah?
Hi, I'm Sarah Egge. Thank you so much for being here today. I worked on the original legislation, and I just wanted to take sort of a walk back in time and remind everybody that at the time this legislation was being authorized, there were some concerns expressed by some members of Congress that this kind of research could lead to rationing of health care, denial by certain insurers, access to life-saving therapies. But I think how the research agenda has borne out by PCORI, those fears have largely been resolved, and I think people are understanding that with the patient engagement that's going on in the research process, that this is actually producing results and evidence that are very useful to patients and providers at the point of care. I'm curious, though, from a political perspective, do those concerns remain on Capitol Hill? Are you hearing a lot about concerns that this kind of research could lead to rationing of care and other troubling aspects?
Could I drill down on that just a second here and just kind of tap it off? The reason that success was there because there was language that I believe, and Sarah, correct me if I'm wrong, that said that specifically prohibited cost effectiveness analysis. Do you think that in the reauthorization that issue will come back as part of the debate?
So what I will say is that we have heard, as we've done these stakeholder meetings, we have heard from stakeholders that are supportive of either eliminating or altering the prohibition on PCORI doing cost-effectiveness research. We have also, on the other end of the spectrum, heard strong opposition to allowing or directing PCORI to do cost-effectiveness research. And so that's I think one of the bigger issues that we'll need to figure out how to deal with as we put together a reauthorization bill.
Would you be willing to stick your neck out and say, is that a Republican versus Democratic issue?
I wouldn't say that it is.
Okay. It's a bipartisan issue. Okay, all right.
We are at the Bipartisan Policy Center,
good.
so yeah.
Good. Anything?
Yeah, I think being 10 years out from when PCORI was originally authorized, we are in a very different climate than we were 10 years ago. And so I think it's a very fair question to ask of whether those same concerns are still present now that there is an entire evidence base of research to pull from. And so I really think that at this point we want to hear from those stakeholders and really get a sense of what they see as working, is not working, what tweaks they might want to see made, and really base our process moving forward based on hearing all sides of the stakeholder feedback.
Okay, thank you very much. Is there any, if there's no last questions, and here's one over here, good.
Thank you guys for being here today. My name is Kyle DeColor. I'm Senior Manager of Policy at Pharma. There was discussion earlier about the impact of low-value care. Could you expand on that a little bit more and discuss maybe any approaches policymakers are taking to address the issue?
Oh, sorry, did you say of low-volume care?
Low-value care.
Oh, low-value care. I mean, so I think at this point it's important to underscore that no decisions have been made in terms of what would be included in a reauthorization bill. We have heard some feedback about some folks wanting to see PCORI focusing more on some high cost research, but no decisions have been made in terms of what would be included in a reauthorization bill.
Well, our clock, we're being told we're finished here, so I guess we better bring this to a close. I want to thank both of you for coming down, and I also want to thank you for your bosses taking leadership on this, and I think it's fair to say that the Bipartisan Policy Center, we don't usually take positions, but on this one, I feel strongly, as I know a number of the staff do, that comparative effectiveness, research, evidence-based policy should be the way policy is made. And from that perspective, we are supportive of the reauthorization of PCORI, and I hope that you're successful, and whatever we can do here to help advance that reauthorization, we're happy to help you out in whatever way we can. So let's thank the staff, and I'll turn this over to Anand, okay? Anand has the second panel. Thank you.
Great. If the second panel could please come up. Well, I want to thank Bill and Alyssa and Moran. I know they had to run out, but I think that sets the stage for what is really topical right now, which is reauthorization of PCORI. But the second panel will really focus on what this research is all about and how it's conducted. And we're really, really thrilled to have 4 terrific panelists here who will be discussing 2 very specific patient-centered research projects. We have about 40 minutes for discussion, and then again, we'll open it up for audience Q&A. I do want to briefly introduce them, and then I'm going to give each pair approximately about 10 minutes to describe their research, and then we'll do a little bit of Q&A before getting to the audience. So to my left here, we have Neely Williams. Neely is the patient co-principal investigator for the PCORNet bariatrics study. She's also the patient co-investigator for the PCORNet Phase 1 and Phase 2 Mid-South Clinical Data Research Network and a community partner consultant at the NIH. She also serves as community principal investigator for the Meharry Vanderbilt Alliance. Next to Neely is Kathleen McTeague. Dr. McTeague is a general internist and an associate professor of medicine and epidemiology and clinical translational science at the University of Pittsburgh. She's the lead principal investigator of the PATH Clinical Data Research Network and a co-principal investigator of the PCORNet bariatric study. Dr. McTeague has a track record of scientific discovery focusing on how body weight influences health, weight management, and patient-centered care. And Neely and Dr. McTeague will be discussing the PCORNet bariatric study today. So thank you for both of you for being here. Next to Kathleen is Patrick Dunn. Dr. Dunn is a senior program manager for Connected Heart Health and the American Heart Association Inside Initiative for the association's new Center of Excellence for Health Technology and Innovation. His role includes the development of science-based care plans for cardiovascular health and a research agenda for health technology and innovation. Dr. Dunn is a clinical exercise physiologist and health educator with 32 years of experience in cardiac rehabilitation, preventive cardiology, and wellness. And to his left, we have Dr. Eric Hess. Eric is professor of emergency medicine at the University of Alabama School of Medicine in the Department of Emergency Medicine. Dr. Hess's research interests are focused on shared decision-making. You'll hear that term quite a bit, I think, over the next 1 hour. Decision science and ameliorating disparities in public health. The overall goal of his research is to investigate and implement ways clinicians and systems can consistently treat patients seeking emergency care with dignity and respect, anyone, anytime, anywhere, regardless of the circumstances. So thank you to all 4 of you. And I think maybe we'll take the first 20 minutes of this panel discussion. And if each of the pairs can take about 10 minutes, and if you can explain to the audience here today what your research is all about, what was the methodology, particularly the patient critical role here, and the results, I think, will be great. And I neglected to mention that Eric and Pat will be sharing data from their study, which is entitled Shared Decision-Making in the Emergency Department, the Chest Pain Choice Trial. So we're going to be talking about chest pain. We're going to be talking about bariatric surgery, obviously 2 health areas that are of critical importance. And let's concentrate maybe the first half of the session just explaining to the audience a little bit more about the study. And Eric, I know you have a slide as well, and maybe if you and Pat want to start for the first 10 minutes, and we'll get, Eric, your slide up.
Excellent. So our study addressed the challenge of how you evaluate chest pain in emergency departments across the U.S. Chest pain is an extremely common reason that individuals decide to come to the emergency department to be tested and seen. And Pat's organization, the American Heart Association, rightly recommends that if you develop the symptom that you're seen as quickly as possible. Because if the symptoms represent a heart attack, you certainly want to identify that and treat it rapidly. So one of the unintended downstream consequences of that public health recommendation is that over 6 million patients present for evaluation of chest pain, and the vast majority of these patients don't have a serious cause for their pain. The tests that we have available to identify heart attacks are very, very good, but they're not perfect. It's sort of at the edge where science is excellent, but it doesn't pick up every single individual. In the case of chest pain, our tests can pick up 99 out of every 100 patients who have a heart attack when they present to the emergency department. And so as physicians, we obviously don't want to miss something that's potentially serious, and so we'll often admit these patients for observation and further testing. But this is discordant from the patient's risk a lot of the times, and patients aren't often even aware that there are decisions being made on their behalf that they could participate in. And so the study that we conducted really tried to address this issue. There was an initial patient representative. His name was Michel Demers. He's a 42-year-old French-Canadian who presented to the emergency department with chest pain and didn't understand the English language very well and was rushed in through a system, and after the initial testing was negative, was told that he was low risk and that he should be admitted to the hospital. And it didn't make any sense to him. Why am I coming to the hospital? And there was some ongoing discussion. His wife arrived, and it really didn't work out and fit into their personal lives that he needs to spend the night in the hospital. And so these two individuals really shared their narrative with us and helped us develop a tool that would help physicians communicate to patients what their risk is and make the management options explicit. You know, there's two equally safe options. You could come in for further observation and potentially testing, which is perceived of as more safe, but you can also be seen in the clinic within the next 2 to 3 days. And if the patient follows up, it's equally safe. So we developed a tool, and rather than walking you through the tool, I thought it might be beneficial just to see how it's used. And we typically would use this tool. It'd be an 11 by 17 piece of paper in which I'd be sitting next to the patient, walking him through it, but just so that you can see what you would see if you were the patient. I've put it on the screen up here. So this is what our tool looks like if I were to hand this to Pat initially. And so it's delivered in the context of you show up to the emergency department, you get your blood taken, you get an electronic tracing of your heart to identify heart attack, and this is delivered in the context of all the test results being back. And so, Pat, in your case, we've obtained blood tests, particularly a blood test to look for heart attack called a troponin, and an electronic tracing of your heart. It's called an ECG. And both these tests are negative. And we can confidently say that you're not having a heart attack, but the next question is, do your symptoms represent signs of a future heart attack or pre-heart attack symptoms? And so we know, based on characteristics of patients like you, there's a couple different options we could consider to better refine your future risk for heart attack. There's a stress test where you could get on a treadmill and run, and we would look at the electronic activity of your heart. There's also a picture called a CT scan, and we could look at the arteries of your heart to get us a sense if there's any blockage. But before we consider these options, let's talk about your own individual risk. So based on your age, what you told to me about your symptoms, the findings on the blood test and the ECG, and your risk factors, we can tell you that out of every 100 patients with characteristics just like yours, 99 did not have a heart attack, and 1 did within the next 60 days. And so this is a picture of the same thing that I just told you. And so now that we have a better understanding of your risk, let's talk about what to do next. Does that sound reasonable to you?
Yep.
And so we have a couple different options before us. The first one is a common path in which you just come into the hospital. We'll watch you overnight and consider getting one of these tests in the next, while you're in the hospital or immediately after discharge. The other option is we can provide for you an appointment. And you can see a physician in the outpatient setting, and they can consider the same type of testing. And as I mentioned, this 1 out of 100 is a 60-day risk. And if you're seen in the next 2 to 3 days, it's been shown to be equally as safe.
Okay.
The third option is if you have your own primary care doctor that you just feel like you have a better relationship with, you're welcome to take that route. But if you chose that, then we would still provide you an appointment as a backup just in case things didn't work out for you.
Okay.
And the final option would be for you just to ask me to make the decision. So if you're not comfortable with it,
right,
based on your own perceptions or lack of clarity. So what is your perception on what you want to do next?
Well, it looks like from the tool that my risk is pretty low, so I'd actually prefer to go home and be seen by my own doctor, in the next couple of days.
Okay. And so do you feel like you have good access to your doctor?
Yeah. Yeah, I can. You know, I mean, maybe if your staff could help me, like, schedule the appointment, that would help.
Great. So we'll work on scheduling that appointment as a backup.
Okay.
And then if anything happens in the meantime, we're open 24/7.
Okay.
You can come by, and we'll be happy to see you again.
So if I keep having chest pain, I should come back?
Yeah, if your symptoms change.
Yeah, okay.
And so this tool that I just walked Pat through, we tested in 6 different centers across the United States in 898 patients, and we randomized patients to their normal discussion with whatever approach that physician normally takes to use of this tool, the decision aid, to have this conversation with the patient. And we found that the patients, roughly half of the 868 who were randomized to the tool, were much more knowledgeable about their risk, their individual risk that I just showed you, as well as that there were management options that you could participate in. They were over 2 times more engaged in the decision, rather than having the physician have more of a typical monologue and just say, I'm going to make this recommendation. There were no adverse events in either arm of the trial, so there were no patients who were sent home and came back with a heart attack related to this discussion. And the number of patients who chose to be admitted to the hospital was 15% less in this group that had this discussion. And so we found that this was a way to make risk transparent with the patient and have them engage in a decision that often the physician would make on their own with more of a fear-based approach to risk. And Pat is now assisting us with implementation and dissemination of the tool. We're implementing it in 5 different emergency departments and 3 integrated health systems right now in a PCORI-funded implementation trial. And Pat not only has the expertise that Anand just pointed out, but he also has interest and expertise in healthcare literacy. So as we adapt the tool to help make the best attempt that we can to ensure that patients understand what's going on, Pat is assisting us with that. And he's also our dissemination partner. And so as we get the findings from our study, Pat has agreed to use his position in the American Heart Association to let the public know, and in his role of connected healthcare and other connections that you have about the findings of our trial. So that's sort of in a nutshell. So back to you.
That's terrific. Thank you. And a nice role play there, a little bit of added bonus. Appreciate it.
Just to add, Dr. Hess asked me if I had a personal experience with chest pain, and unfortunately I hadn't, so I had to kind of make it up. Actually, fortunately, I haven't had that experience. So I had to, but anyway.
Great. Thank you. Kathleen and Neely?
Sure. So let me just start telling you a little bit about the background of our project. We're focusing on bariatric surgery and severe obesity. I think probably everybody knows the U.S. is in the midst of an obesity epidemic. You may not realize, though, that severe obesity is increasing, the prevalence of severe obesity is increasing more rapidly than less extreme forms of excess body weight. It's very difficult to treat severe obesity. In fact, lifestyle remains very important for people who are larger, but only results in typically modest amounts of weight loss. Bariatric surgery is the most effective way to treat severe obesity. And the other thing to keep in mind is severe obesity has a significant health impact, increased mortality, increased risk of all kinds of health outcomes like diabetes, hypertension, certain kinds of cancers, poor quality of life, loss of mobility. So we were very interested in the idea of decision-making around bariatric surgery and how the different procedures compare. And we looked at 3 different procedures, the most common ones in the U.S., Roux-en-Y gastric bypass, which is really the gold standard. It's been around for a very long time. Sleeve gastrectomy that burst onto the scene in the last 10 years and has taken over the marketplace in many areas. And then adjustable gastric band. And when you look at what the other pattern in terms of adjustable gastric band is that that's become really less and less common over the last decade and is not really done that often at this point. So we worked with PCORNet, and we'll mention that in a minute. We worked with 45 different health systems and examined data from 46,000 patients, and we used a very patient-centered approach. And I'm going to let Neely Williams, who's one of our patient co-principal investigators for the study, tell you a little bit about what that meant in terms of the actual study.
Thank you, Kathleen, and certainly we are grateful to have this opportunity to share this as a patient. It was very meaningful for me. It allowed me to be able to be a part of the discussion, to find solutions and make decisions about how bariatric surgery impacts the lives of folks like me. many of the things that we discovered, or many of the discussions that we had, and we had many conference calls. I was involved in this project before it was actually a study to be had. We formed a task force type group across the nation that came together and decided on what type of questions would we want to ask about bariatric surgery. That group consisted of clinicians, payers, and patients, both professional patients and non-professional, non-medical professional patients. And we developed a written request to PCORI to fund bariatric surgery, or to obesity study, rather. We made a request for there to be funding allotted for studying obesity. And from that request, two projects two forms of studies were allocated, and that was for adult obesity as well as for adolescents and the impact of antibiotics on adolescents and the outcome for their BMI over time. So having been involved from the initial concept has been very meaningful for me and for the community that I represent. It allowed me to be able to ask some questions, to be a part of discussions in ways that were unique. It was not just my voice, but it was the voice of patients that I hear throughout the work that I do. I work in the community and serve on many individuals who are impacted by health disparities and the social determinants of health throughout the greater Nashville area. From folks who've dealt with things such as HIV and AIDS, and then substance abuse. I have many relationships in that area. And so I'm often in forums and settings where people are discussing the impacts of things that touch their lives. And so certainly it was meaningful for me to be able to have that opportunity and continue to be a part of the dissemination of the information that we've gathered from that, such as this setting here today, and further involvement in the decision-making project that is soon to come on the scene. And so it's empowering, and I am committed to continuing to develop to be a part of the discussion as other things are developed, so that patients on a broader scale can be able to be a part of the solution. IOM, I'm sorry, Institute of Medicine has suggested that it is most important for patients and stakeholders to be engaged in the process. And that is truly been borne out in the work that we've done through this obesity study, and other studies that are coming forth across the nation. So we're grateful for that, for having to be a part of this time where folks are really taking this issue seriously. We know as patients that before there's any data, there are individuals. And each point of data represents someone's life. Someone has a story to tell about the significant impact that it's had on their lives. When we move it from a personal level and look at a national level, we're talking about the cost being a 6-point-some trillion. Well, how could that cost be reduced if we find solutions that will help people to live better, to be able to be healthier, and to have less likelihood of having to have those adverse effects that are related to obesity? We have to be, it's bi-directional. Partnerships between patient and patient advocates, the patient community, both have to be able to benefit and bring their resource to the table. We have the same goal to increase the health of individuals across the nation. And if we have the same goal, there's no reasonable reason that we can't work together and continue to work together. And I've found so many folks who have been able to come aboard and openly embrace the idea. And I certainly hope we can continue from today to press that lever even further, because the need is great. As we see the emerging of the opioid crisis and the other many health crises that are out there looming in the distance, we know that we have to make a difference. We have to move forward. And so I'm just grateful to be part of the team as a patient and as a consumer and as a person who care about those young folks and those children and the families and the communities that won't come to the Bipartisan Center, but they are going to be impacted by everything that happens here. So we thank you for that.
Great.
Neely, yeah, please, Kathleen.
So can I just summarize a little
Yes,
bit about
yeah,
what we
great.
found?
Yeah.
So Neely and our other patient partners really helped us not only form the initial question, they helped us operationalize how the study would be carried out all the way through. In the end, the major comparison is really between, for most patients, is between sleeve gastrectomy and Roux-en-Y gastric bypass. Even though sleeve gastrectomy is the main procedure in many areas now, there was no long-term data comparing the two. We found when we looked at weight loss that they performed pretty similarly, that Roux-en-Y led to a little bit more weight loss than sleeve gastrectomy, and that weight loss would peak at about a year and a half out, and then they would regain a little bit over the next 4 years. When we looked at diabetes remission, one of the main reasons many people want to pursue this surgery, we found that, again, fairly similar performance between the sleeve gastrectomy and the Roux-en-Y in terms of remission. And that both of those procedures perform much better than the adjustable gastric band. The Roux-en-Y gave just a little bit more, about 10% more remission than the sleeve gastrectomy. However, when we looked at diabetes relapse, the two procedures diverged. So this is people have the surgery, they lose weight, their diabetes goes away, and then for some patients, diabetes comes back. And in this case, we found that the Roux-en-Y procedure performed better than the sleeve gastrectomy. However, based partly on input from our patient partners, we also had an emphasis on adverse effects of the surgery. The sleeve gastrectomy procedure had fewer rehospitalizations and reinterventions. So basically, at the end of the day, we feel like we're really pleased that we came up with data that should be helping clinicians and patients as they sit together and try to decide for patients who are interested in bariatric surgery, what's the right procedure for you? If you have diabetes, for instance, the trade-off of having a little bit more of a risky procedure might be worth it, because if your diabetes goes away, it's going to be much less or somewhat less likely to come back. So we used, I think the other important point is we used real-world evidence. We used data that's been sitting in the electronic health records. We used it efficiently from real patients and real providers, and our patient partners have helped us to try to make sure that the data that we've got is going to be helpful in their decision-making process.
That's great, Kathleen and Neely, thank you, and I think that's a great introduction to both studies. And I think where I want to start, and maybe Pat and Neely, we'll start with you first, really honing in on the role of the patient principal investigator, patient representative. I think it would seem to most people, I think, hearing this, that this is the way we ought to be doing research in this country. Just like we have a standard of care, so this ought to be the standard of clinical research practice. Can you talk a little bit more about why we aren't there, how we get there? Certainly, I'm assuming patients are interested in being involved early on in designing studies. How do we have a paradigm shift to ensure that these aren't just innovative examples, but this is really the standard of clinical practice? It would be great to get your perspective on the role of patients and how we ensure that patients are part of this process.
Well, for me personally, my experience, if you don't mind me going first back here, is that being involved is a personal choice, but it's also about being able to be in an environment where you can bring forth what you offer to the process. So I think as I heard in the earlier panel about a cultural change or shift in the way research is done, this is not about making researchers the bad guys and patients the poor victims. We're not victims, and we're not at the mercy of researchers. But patients will not typically invest their time and their energy into a process that if they've not felt welcome and trusting of the process. So we have work to do, and our process was very informative It very, very enlightening for me because it allowed me to be a part of the conversation completely through the process, even in those areas where I felt less comfortable. Searches around some of the analysis and the different techniques that have to be used, methodologies around research. But I had a team that was willing to educate, who was open to answering questions that I raised for clarity, allowing me to learn as I go. And now we really want to take what I've learned and use it in ways to further educate future patient investigators so that they will be able to bring even more to the table to be part of the discussion around the process and the outcomes of the research. One of the learning points for me was in the beginning of the study, I had no idea the role that I would have the opportunity to play in the dissemination of the information. And that is crucially important to me, that not only that great research is being done, but that research gets back to the people it impacts the most. And that is those persons that's dealing with that particular disease, whether it's heart disease or cancer or HIV or obesity and diabetes, all of those things. We hear these conversations in our community as individuals. I often say I can hear the conversation in the academy, in the institute, but I can also hear the lady in the dollar store who's telling the story of how her life has been impacted by having to go to dialysis, or how her life is impacted by the medicines, the different medicines she's taking, and whether she trusts that those medicines are doing what they're supposed to do. And nobody's heard her voice. And so it is our job, it's I can't imagine that I can take on many more missions, but I'm going to stay in the game as long as I can to continue to do all that I can. But it's not about me. It's about making sure that the role and the functionality of co-PIs, real co-PIs, not ones that just bow nicely and leave the room, but ones who stay around and ask the questions. Now, I heard you say this, but how does that impact the way patients will impact the patient that will be practiced on? Have you considered this? And those are the ways that this team allowed me to participate. So I think that there's much to be learned from what we learned, and there are further learnings to be had for sure.
Amen. and just to add on to that, a key part is the messaging. How is the information being communicated to the patient, from the clinician to the patient? What I really like about the decision aid is it provides a format for that discussion to happen. It has a visual, so if the person's visual, they can see the graph. It also gives some clear choices for the individual, because a lot of times the communication the person still may go, okay, but I still don't know what to do. So it's very clear. It also gives them the choice to opt out of making the decision and saying, I don't really know, can you please make the best decision? I think a lot of times what's lost is, there's a power dynamic or a power gap between the clinician and the patient, especially at this time. And it's not just about, it's a doctor. There's a lot of fear, a lot of anxiety, that there's a lot of stuff going on in that patient's mind at that time. But there's also a knowledge gap too. So the clinician and the patient don't have the same level of knowledge and perspective. So what the clinician has is the deep knowledge of what's going on here. And what the patient has is the contextual factors. The patient might need to go home because they don't have child care, or they're afraid of getting an infection or something. So bringing those two things together, the knowledge and the context, I think is where some good things can happen.
That's great. Eric and Kathleen, to follow up on that, when I think back to medical school residency training, I don't remember any courses on shared decision making. You guys are national experts on shared decision making, and a lot of stakeholders here. What's your sort of message to policymakers about the importance of shared decision making? How can policymakers support shared decision making vis-a-vis clinical research. So educate us about sort of the burgeoning field of shared decision-making, why it's so important, why providers need to get on board, what can policymakers do to support shared decision-making.
Well, let me tackle the important piece. And I think for many, many clinical decisions, there's no one right answer for every patient. That there can be multiple treatment options. They all have trade-offs, and they not only have trade-offs in general, they also have to be balanced with the types of things that Pat just laid out, like what do people's social situation look like, what are their values look like. And so in order to make the right decision for the right patient in a given moment, you need to actually factor all those things together. And some of it is technical expertise, which the physician can bring to the discussion, but some of it are things that only the patient knows. And in the end, it's a complicated mix of information that has to be brought together to make the right choice.
That's great.
I think there are a number of approaches that are being taken to try to make shared decision-making something that physicians do with multiple decisions. And there's several folks that are working on changing medical school curricula, so it's something that it just becomes normal. So when you graduate from medical school, you think that's the way it should be. There are a number of specialties who have worked to get shared decision-making recommended in their guidelines. So that's another approach. In terms of getting practicing physicians to start using shared decision-making after they've been out of medical school, that's the challenge right now, and sort of working on how do you, in a nuanced way, consider the various incentives that are possible from a policy perspective to encourage this type of discussion. And there's some discussions along the lines of having like the National Quality Forum, getting them in line, and getting perhaps a billing code of like a CMS-type billing code that could be used to encourage physicians to actually leverage their time in this way, because there's multiple different things that are pulling at our time and different priorities. And so there's a number of different angles depending on which people group you're trying to influence.
Let's just, yeah, please.
Just to quickly add, we've actually added, we being the American Heart Association, has begun adding shared decision-making into our guidelines. So we recently announced new primary prevention guidelines, and now having the conversation with your doctor is part of the guideline. It's also in our cholesterol guidelines. You don't just treat the number, you don't just treat the LDL cholesterol. It's a conversation that needs to occur based on those contextual factors with the individual.
That's great, and I think, Eric, you're probably also referring to Choosing Wisely, which is one which I hope many of you take a look at, but one important effort by the American Board of Internal Medicine Foundation, which takes services, there are I think several hundred now, where there may be insufficient evidence and really calls for doctor-patient discussions and conversations about whether those services are appropriate. So, so I think that's very helpful. Maybe Pat and Neely, back to you. What advice do you have to healthcare professionals as they think about thinking about patients, involving patients more so than they have been in clinical research really at the outset? What's your advice to healthcare professionals out there?
Well, certainly being open to embracing this new reality, that patients aren't going anywhere, that they're going to raise the questions, they're going to be there to express a need for what is being done. I think back to my personal experience often as when I was, first of all, when I didn't have access to the surgery. And then secondly, once I had access, the kind of consultation I received. And I received what was typically known as, at that time, was from the perspective of a surgeon who had done many procedures, who was good at doing those procedures, and he gave me the best advice he could give as a surgeon who was confident in doing the work that he'd done. I also had the advice of my primary care provider, who had been educated a traditional way, that really had not taken into account that obesity was not a choice but a disease, and had really worked from a model that suggests if you just do A, B, and C, obesity ceases to be a problem. And when you're caught between those two perplexities, it's difficult as a patient to know which one do you listen to. But now that we have opportunity to have tools that will help us to make more informed decisions, much like Dr. Hess's tool for chest pain, also for around what does surgery really look like? What are the outcomes from some of the studies that have shown what the impact of having the surgeries are? Those things will help clinicians and other healthcare providers to invite patients in the room and create an environment where patients can be authentic and share their story, share their process, and help to inform them in ways that they had not ever had before. That a patient really has something to say about how this thing will impact their life and how they can make a better choice, and it will be better for both the clinicians and the service providers as it will be for the patients.
That's great.
Pat? And I would just add that it's not a one-size-fits-all approach. There are some patients that are very proactive, self-directed. They want a lot of information, and they want deep information. Others are very reactive and only give me what I need to know. Some people like choices. Some people want direction. Some people like to set personal goals. Some people are focused on the people around them. So my advice is just, even take it to the next level, go deeper into really trying to figure out not just clinically what's going on with the person's biology, but what's making them tick in their mind. What can help them really make good, not just short-term decisions, but good long-term decisions for their health.
That's great. Eric and Kathleen, maybe you can talk a little bit more about next steps now. So you touched on dissemination and translation, but all of you, the four of you and others, have created some important tools here. I think Eric and Pat, in your case, you're back to the value question. How are we generating value to patients in the healthcare system? You've created a tool that, particularly for low-risk patients, might lead to choices in line with their preferences and may lead to a reduction of services that may not be necessary. Particularly, we talked about some of the overuse of healthcare services. I think Kathleen and Nelia, you all now have a tool, particularly for patients with severe obesity, that may help them in their decision-making process of whether to proceed with surgery or not and which surgery is the best. Talk a little bit now about, and we'll get into this in the third panel in several examples, but elaborate a little bit more on the dissemination and translation for both of these studies and how you're now going into additional hospitals and health systems, and over the next couple of years, how you hope to get more people to experience this tool, utilize this tool in the quest for better health outcomes.
Sure. So for the bariatric study, right now we're largely at the stage where we're just trying to get the word out of what we found. So we're writing about not only the findings in terms of the procedures, but also in terms of our experience with engagement so that we can help other researchers do engaged research as well. But our exciting development of the past month is that we recently received funding for embarking on a shared decision-making project. This is going to be led by David Arterburn, who's not here today, but was also the lead PI for the bariatric study, and he has helped to develop and test a shared decision-making decision aid over more than a decade. And we've already updated that tool with the data from the bariatric study so that we've now actually got it in a very nice booklet format that patients can read on their own, discuss with their doctors, and use as they're considering whether or not bariatric surgery is the right thing for them, and if so, which procedure they might want to get. And so we're going to be rolling that out at two very different health systems, both Kaiser Permanente, where David is based, and then at UPMC, which is where I am based, and basically we're working with primary care providers and surgical teams at both of those sites, and making the tool available, training them how to use it, and hopefully we are anticipating that this will lead to better conversations and better decisions about whether or not to pursue surgery.
That's great. Thank you. Eric?
Yeah, with our implementation study, we're taking a couple different approaches. One is we're developing an implementation toolkit, which is it's clearly defined recommendations for a new hospital who's trying to implement our shared decision-making tool, and it largely involves change management, such as who's supposed to be on this type of team, what type of different skill sets do you need when you want to influence the practice, and how can these key stakeholders at each hospital, such as, for example, a nurse manager, an operations manager, the physicians, and others, how can they adapt it so that it meets their specific health context and bringing the right people to the table. And I think the other sort of unavoidable element when you're seeking to implement new findings in science and get it used at the bedside is it really needs to be integrated into the electronic health record. And so we, in our study that we're doing right now, we have 4 of our sites actually, that are on the Epic healthcare platform, and 2 of the sites that are in the Cerner healthcare platform. So those are the 2 biggest healthcare EHR vendors. And we each the investigators are working at their own sites. Their IT department is not only developing the code, but we're going to make it available online so that it can be used by other hospitals as well. So really kind of a focus on change management, as well as practically how do you get it into the record so the frontline clinicians use it.
Great, great. Well, I think at this time, let's open it up to audience question and answer. And again, we have some roaming microphones here. Yes, please, in front.
The focus here is appropriately on the patient personality, but the physician personality, that's ceding a lot of power, and a lot has already happened, but how much of a problem is that?
Well,
in
my experience, it really kind of depends on if a physician's been in practice long enough, what were they influenced by, and what are their current practice patterns, and how malleable are those practice patterns. We certainly have physicians that are set in their ways, and they can't imagine a role that a patient would have in a decision, versus younger, malleable ones that think it's totally the approach that should be taken. So definitely run into that.
I think we focused more on the patients this morning, but I should mention that actually, our 45 different sites each engaged a stakeholder, and some of those sites engaged a patient, and many of them engaged a surgeon or a health system leader. And so, by having those voices in the room as we develop this and plan the next step, we are hoping that actually we actually ask the questions that not just the patients wanted the answers to, but that the surgeons are looking to the answers for, because they want to use that in their counseling as they are making decisions around their own care. So I think that you bring up a good point, that the clinicians are a really important partner in this whole process of patient-centered comparative effectiveness research.
It goes back to health professional training as well, and getting to clinicians before they're set in their ways. Yeah. Great. Yes, we have 3 hands here up in the front, and then we'll just go back. Yep.
Thank you. Stacy Bridges, patient advocate. I was wondering, what role do today's drugs play in as far as the heart attacks, strokes, diabetes, sudden death, homicides? What role do the drugs play, and how does that fit into your study, or is it in your study?
And just to clarify, so you mean medications for these conditions, or did you mean?
Every drug, I don't care what condition it could be. Any drug that's advertised on TV, I don't care if it's for leg scratches, the side effect will be heart attack, stroke, suicide, or sudden death. Are you looking and addressing the actual side effects, and have these drugs been researched, and are there blocked data that's preventing the doctors from sharing that information to the patient? And is that the reason why there's an increase in diabetes, obesity, and other disorders? Is that clear?
I mean, and maybe to help, I guess in terms of shared decision making, one of the critical pieces is particularly, neither of these trials necessarily had a medicine, but Kathleen and Erica, you might want to talk about, from a shared decision-making process when medications are involved, how do you talk about risks and benefits of different drugs, and how do you work that into the options and the choices patients have. And Neely and Pat may want to weigh in as well.
Yeah.
Yeah.
Well, I know that there are some shared decision-making studies that are focused on the choice of drugs. One of the most common ones, there's a trial that's ongoing right now that is funded by the NIH that's looking at choice of medications to prevent stroke in patients with atrial fibrillation, and really kind of laying out the differences between the choices and how it might affect their lifestyle and how much the cost might affect them as well. So there's definite a whole area of shared decision-making that's focused on choice of medications.
And in our cholesterol guidelines, so instead of in the past, you would just look at the LDL and prescribe the statin. Now, with the guideline, it's a conversation between the clinician and the patient, and then based on the overall risk of a cardiovascular event, there's a shared decision-making event then, as far as how aggressive to treat that individual.
That's great. Yes, please.
Hi, I'm Gary Filerman. I want to comment from the perspective of being a board member of the Accrediting Council on Continuing Medical Education. I don't speak for ACCME, but it is a vantage point from which it seems to me that comparative effectiveness of continuing medical education is a critical issue in all the translation comments that you have made. We don't know what works very well. We do know that a number of entities, like in the cardiology field in particular, one I'm familiar with, have extensive investments in elaborately tested and for their efficacy CME outreach. But the fact is that there's Dr. Smith and Dr. Jones have their office up there. They're 30 years out of school. We assume, their patients assume that they're up to date, and they assume that everything that you've talked about is somehow affecting how they practice every day. We don't know if that works. And I would argue that comparative effective research into translation is the issue of the day.
Well said. Any comments on the importance of?
Yeah, it's very important. If you're going to have effective counseling and effective conversations, it's critical that the healthcare provider be effectively up to date and know the technical side of all the aspects that they're supposed to be helping make sure enter the conversation.
I sort of like we need some comparative effectiveness of the continuing education out there, because I don't know to what extent that comparative effectiveness research is integrated into the continuing education. So I think that's a really important point. Yeah. Other questions? I think there's two in the back, or one in the middle, one in the back. Oh, and then we have two on this side too, Bill and then the back. Yeah.
Alyssa Kane with the Patient-Centered Primary Care Collaborative. We talked a little bit about the dissemination strategies to disseminate these results to clinicians, who then we're assuming are effectively communicating the results to their patients. But is there any work being done to translate these results into language that patients are going to understand? And what kind of evidence is being used to ensure that that translation is happening in a way that patients are actually going to understand it?
Great.
I can't speak to how the research on how effective these late translations have become, but I can share with you that I've been a part of the work that has been done on our obesity study as far as developing a late translation of our findings, and so I'm very hopeful, and certainly have seen other places where the breaking the information down into language that the patients can understand has been very helpful in every aspect of them being able to take advantage of the findings that come from the research. It's so important that we speak the right language, so that each one can hear, and I think that's bidirectional also. That patients have to be able to have some sense of what the language is from the scientific perspective, but we also have to have language that patients can internalize and operationalize in ways that will help them to use the information.
And I think the decision aid is a first step in that translation. It's a tangible, thing that can be used to help that patient understand, the information. Of course, it needs to continue to be tested, for the effectiveness of the translation.
I think one of the things that PCORI has done differently, and I think done well, is whenever you're writing a proposal to get an allocation of funds to do research, the dissemination is a key aspect of the application. So much so that when you think about who you want to engage in the study, you need to think about who are the people groups you need to influence based on the findings of the study. Do you need a policymaker? Do you need a payer? Do you need, which patient representatives of which groups need to be engaged? And each of those individuals are really the expert in translating the findings into the language of the people group that they really interact with most frequently. And so that's one of the elements that I think PCORI has done really well that I hope continues.
Wait, one question in the back, yeah.
Hi, Kevin Fahey. I'm a consultant that was previously connected with PCORNet, and this is to Neely and Kathleen, really. I think you know that I've been following this study from the get-go when it was sort of, as Neely talked about, an idea that was out there as to how do we do it. I wondered, since this was a demonstration project for PCORNet, and it has turned out, I was thrilled when David, you all had that first article out last year, that it had such great results, but I wonder if there is one or two key lessons, and besides making sure that you have a patient advocate like Neely on board, that's the first point, but are there key lessons for researchers studying other conditions in applicability of the methods that you used? How can that be a learning for that researcher who has the idea out there what they want to do?
Yeah, I think that, as you point out, this was one of the very first studies in PCORNet. And we came out with all kinds of lessons learned. We are working hard to try to make sure that we disseminate findings in terms of how to engage stakeholders effectively. I mean, I think that the fact that we made it a requirement that every site engage a stakeholder to be part of the study helped make sure that we had a diversity of viewpoints involved as well as a geographic diversity of stakeholders' input. The comments that have been brought up around being careful around language are really critical. We tried to be very careful to communicate in non-technical jargon, but I'm sure Neely can tell you that we slipped up on that a lot, and she would call us on it, and it was really important. There was a number of discrete tasks that the patient partner's input was incredibly useful on, including, when we had too many patient subgroups that we wanted to look at, we wanted to say, well, how do our findings differ based on patient age? How do they differ based on racial ethnic background? We had 10 different things we wanted to do. We didn't have enough money to do them all. We went to our stakeholders, our patients, our health system leaders, our clinicians, and said, which ones do you think are most important? And we used their perspectives to try to figure out which ones to prioritize. And then, of course, this was this new PCORNet infrastructure where PCORI has built a network of networks that has standardized electronic health record data in health systems across the country to try to make it more efficient and easy to use real-world evidence to understand what's happening in patient care and which treatments work best. And so we learned so many different things. I'm not going to go into them all here, about how to use those data effectively and to find answers to questions that matter to both the patients and the providers.
Really quickly, two other lessons learned that I certainly would want to hold up to any researcher or anyone interested in this process is budgetary and education. We definitely know that we have to enter this process recognizing that budgets need to be inclusive of engagement in a more significant way. It cannot no longer be an afterthought. It has to be something that's part of the initial onset for how you're going to carry out the research and how you're going to disseminate the findings. So budgetary effects, and not only just a dollar amount for the budget, but talking to patients about how that would look. because often when patients are involved in research, most often they will not have the infrastructure to support them getting to places where they need to be a part of that research activity, for conferences and things of that sort. And educational-wise, there definitely needs to be education, time spent to help bring patients and other stakeholders up to speed whose their natural language is not that of science, so that they are able to come into those discussion activities empowered to be able to be a real participant and not there sitting, working on a learning curve, but having the information they need up front so that they can be a part of the dialogue.
That's great. I think we can probably just get to two last questions, Bill, and then in the back, and then we'll move on to panel 3.
Hi, good morning. I'm Phyllis Greenberger from Healthy Women, and I've spent the last 26 years working with the government in terms of sex differences. And nobody's mentioned anything about the fact that we still don't have a whole lot of information on how different medications affect men and women differently, and also ethnic minorities. And also in terms of heart disease, there's differences in diagnosis and the way men and women present, and how is that information being transmitted?
So, gender differences were one of the subgroups that we did look in our study, and didn't find a lot of big differences in terms of that particular question. But I think that my point about how the bariatric study was one of the first studies out of PCORNet is really salient to the concern you raise. Because PCORNet has taken electronic health record data across many, many different health systems and standardized it. And that means that if at University of Pittsburgh Medical Center, they code male as M and female as F, and at Johns Hopkins, they code male as 1 and female as 2. When you put your data into the common data model, they clean that all up, and everybody codes it the same way. And it basically makes it so much easier to do research using real-world evidence. So that PCORI has built this tremendous resource of electronic health record data along with infrastructure and relationships to use it effectively, and those kinds of questions could be answered very effectively using PCORNet.
Thank you. Thank you, panelists. Very nice. I enjoyed your discussion. A lot of discussion about shared decision making. I guess just a general question, particularly for the clinicians. Sharing that with the patient, are you as clinicians willing to share it with an algorithm and the algorithm back to you as clinicians? AI, talking about the doctors that's been out of school for 30 years. What's the future of AI in this world?
It seems like the risk prediction models are just going to get more and more precise, and we'll be able to break them down to individual differences, particularly when you can start to take into account some genetic differences and have those as a baseline background information. And as this information becomes more readily available to clinicians, it will definitely inform our decisions in ways that are probably superior to the way we diagnose things. But at the same time, I think the clinician's experience combined with understanding the patient's setting and their situation is really still an absolutely critical part, and probably always will be. But hopefully the risk prediction improves over time.
Yeah. I mean, it strikes me as just one more piece of information to factor into the decision. And the physician's going to be responsible for understanding what the assumptions are and how they might apply to that given patient, so that they convey that effectively as part of the decision-making process.
Well, this has been a great discussion. I want to thank really all 4 of you for your leadership, your expertise, your advocacy, and really the time that you've spent with all of us and traveling here from Nashville and Pittsburgh and Dallas and Alabama. We really appreciate it. Thanks very much. Thank you. So at this time, I'd like to invite our 3rd panel to the stage, and the 3rd panel will be moderated by CeCe Conley. CeCe is the president and the CEO of the Alliance for Community Health Plans. Many of you know CC. She spent more than a decade in healthcare, first as a national correspondent at the Washington Post and then in thought leadership roles at 2 international consulting firms. We're very thankful to have ACHP as a partner here and CC here, and a tremendous set of panelists. Thank you.
Thank you, Anna. And good morning, everyone. Thank you. I've been eavesdropping behind the scenes, and that was a wonderful conversation. And we're going to try to wrap it all up in a nice bow here with this discussion, where hopefully you're going to hear some wonderful examples of taking some research and the way in which it can really be broadened out into system impact and a system conversation. So that's what we're going to attempt to cover in our dialogue this morning. We at ACHP are really thrilled to be co-sponsoring this wonderful event this morning. We were the beneficiaries of a PCORI award about 18 months ago, and what came out of that were 11 case studies from our nonprofit member plans. We titled that report Accelerating Adoption of Evidence-Based Care, Payer-Provider Relationships. And I'm thrilled that Dr. John Bolger is here as one of our case studies to share with you. But really that grant gave us the opportunity to dive in and look at a model that we've long believed in with both health plans and provider entities coming together. We've often felt that it was better from a patient outcome perspective and a community perspective, as well as cost. But now we really have 11 good case studies to put out and share with the broader community. So that is a credit to PCORI for seeing the importance of that study and supporting it. I think the other thing that makes this panel discussion especially fun is that we have a very diverse group of speakers and case studies to share with you today. And so in the course of this conversation, you're going to hear some very exciting work with respect to treating hepatitis C. You're also going to hear about diabetes and, more importantly, pre-diabetes predictive modeling, which when you dig into the numbers in the United States alone, it's a staggering threat to our nation. And then also mental health and all of the complexity that right now is going into screening treatment of mental health. So I think it's a really wonderful, broad, diverse collection of views and case studies for us to close out the morning with. So with that, I am going to tell you each of our panelists in alphabetical order, and then I've invited them to take just a couple of minutes and share in their words a little bit of their case study to kind of set the context for, I hope, a nice conversation that you all will join us in. Anybody who's heard me speak knows that I come from a large Irish Italian Catholic family, so I really do invite you to jump into this conversation because that's what I grew up with. But let me tell you about the very distinguished panel joining us here. To my immediate left, as I mentioned, Dr. John Bolger, who is the Chief Medical Officer of Geisinger Health Plan, situated in central Pennsylvania. Fun factoid, my mother was born at the original Geisinger Hospital, so it does mean I'm a teeny bit biased, and they are also a member of ACHP, so welcome. John, besides being the CMO at Geisinger, he is president-elect of the American College of Osteopathic Internists, and really known and respected as a leader in quality and patient safety movements across the United States. Coming next in the center alphabetically, Dr. John Cuddleback is Chief Medical Informatics Officer at AMGA, which many of you know stands for the American Medical Group Association, and he sits over their very impressive analytics division at AMGA. Much of John's work has focused on comparative data and meaningful benchmarks for clinical outcomes, so I think nicely bringing together the data with the actual health outcomes, and we're going to hear more on that from John. And then at the far end, another fellow Pennsylvanian, Dr. David Kelly, is the CMO at Pennsylvania's Department of Human Services Office of Medical Assistance Programs. And in that capacity, he is overseeing both the clinical and the quality aspects of those programs that are covering about 2.5 million beneficiaries today. And looking at David's bio, I also was struck that he has been very engaged in many of what I would describe as the hot topics in healthcare these days. When you look at alternative payment models, the use of telemedicine, really some very innovative work going on there in my home state. So we are thrilled to have the three gentlemen with us, and I am going to start with John and ask you to just talk a little bit about the Geisinger case study.
Sure, thank you, Cece. It's great to be here to get to talk with everyone about this. We were involved at Geisinger in, as Cece said, with the ACHP's collaborative, and it was really focused on dissemination. It was talked about a little bit in the last panel. And I think we all know that, and have seen the numbers, that there's a lot of data out there on how physicians should treat patients and how healthcare teams should take care of patients. But we also know it takes 17 years to get from, there's been a study published, and this is absolutely the right thing to do, no question about it, to where it actually gets into practice and is actually touching people on a day-to-day basis. So we were focused on that. Our particular topic that we focused on was hepatitis C at Geisinger, but the ACHP initiative looked at things like early elective deliveries, opioid treatment, diabetes and hypertension prevention, surgeries, a number of case studies. As Cece said, there are 11 of them. And what we found by working together, and the goal was really to say, well, what's the implementation science? What works to get this so that it doesn't take 17 years to get it out in practice? And what makes it stick? Because a lot of times healthcare organizations go out and try to put something into practice, and it works when you're really focused on it for 6 months, but then you look away and start to do something else, and you get beach erosion, and those good things that happen go away. So it was, one, how do you get it implemented, and then two, how do you make it stick? And what we found, and there were a couple really key things. One was building consensus. The question was asked in the last panel, how do you get the physicians to give up something? How do you get everybody involved? And that really has to be addressed up front, we found. You have to get the teams together and build consensus around, what is it that we're trying to do. The second piece of that was, and you've heard me say it a couple times already, it needs to be a team. So it's not just physicians. It has to be physicians. It has to be patients, as we heard a lot about in the last panel. You need to have other members of the team, be they nurses, pharmacists, social workers, whatever it happens to be. And that team actually is one of the biggest keys to making things move forward, because sometimes, in our case with hepatitis C, after the consensus was reached and the team came up with what they wanted to do, it was the pharmacist that took most of the lead in making sure the implementation happened and the implementation stuck. In other things, it might be a nurse. In other places, it might be a physician. But if you didn't build that consensus and you didn't get a good cohesive team in the first place, you'd never be able to get down the line. The third thing we saw was having education for each different view of what's going to happen. So the physicians need to see one view, the pharmacists may need to see another, and very importantly, if you're going to pull the patients in, they have to be educated as well and have education that is focused on them. Again, we heard a lot about having that at the right level so you're not using jargon. The fourth piece was being able to have the data and the data transparent so that everybody can see what's happening. You need the data of where you are when you start, but need to get people the data and have them be able to feel comfortable with it about what's happening when you're implementing it. And the data, when you're doing that, becomes very powerful because you see light bulbs go on really in the team and say, oh, gee, I didn't realize it was that way, or I didn't realize, the physician sometimes will say, well, I didn't realize it affected my patients that much from a cost standpoint or cost share. But that data transparency was extremely important. And the last piece we looked at specifically was how do you align the incentives? In our case, we were looking at delivery organizations, healthcare delivery organizations that were lined up with a payer, and how do you align the incentives between the two of those? Because I think we all know many times, at least people's view of it is those two different places are fighting with each other to some extent as to the payment. And how do you, when you get them aligned and you say, well, this is really better for the payer, it's better for the deliverer of care, in the end, that ends up being much better for the patients we're taking care of. And if you get all those things aligned, these things tend to get implemented much faster and they stick. So the goal around what we were doing from that, the model is how do you do that implementation science? How do you get that 17 years down to a year or 6 months? And then how do you make it stick? And then how do you take that and move it and implement it on other disease states so that it's spreadable to other things? And we'll talk about, as we go through the question and answer, how that success played out.
Wonderful. John, please.
Well, thanks, Cece, and thanks for the opportunity to be here. PCORI, of course, emphasizes personalization of treatment, and we have 2 AMGA member organizations working with researchers at Tufts Medical Center on a predictive model for people with prediabetes. It's an example of precision medicine without having to wait for genomics. We can combine data from clinical trials with the data that we already have in our EHRs to create individualized estimates of benefit and risk to inform shared decision making. Clinicians tend to think that anyone who would have qualified for a clinical trial will experience the average benefit that was seen in the trial, but actually there's a wide range. It's possible often, using data that were available at the beginning of the trial, when you look retrospectively, to identify a subgroup of patients who got a lot more than the average benefit, and maybe another subgroup who got less than the average benefit. This concept is called heterogeneity of treatment effect, and it was actually a PCORI methods study on heterogeneity of treatment effect that where this model that we're using originated. We currently have about 150 AMGA member organizations participating in our foundation's national campaign to improve care for 1 million patients with type 2 diabetes. And our members are actually making a real impact. After 2 years, they were up to 750,000 patients affected. And in about 1/3 of the cases, it's a result of screening. It's identifying people who didn't know that they had type 2 diabetes and found that through screening and began treatment. And that's really important because 1 in 4 people who has type 2 diabetes is not aware that they have it. And for people over 65, it's even greater. So for the problem, though, is for every person with diabetes that you find in screening, you find 6 people with prediabetes. And the care system seems kind of overwhelmed by that. And so you need tools to kind of prioritize intervention. So this idea of understanding individualized benefit and risk turns out to be very useful there. Without intervention, a person with prediabetes has about a 25% chance of developing diabetes over the next 3 years. That came from a landmark clinical trial, and since John mentioned 17 years, it was published in 2002. It's now 2019. They looked at 2 interventions, either taking metformin or, which is the first drug that's actually used to treat type 2 diabetes, but it has an effect of preventing diabetes in people with prediabetes, or a very intensive lifestyle program. Overall, the lifestyle program was twice as effective as metformin. It cut the risk of developing diabetes by more than half, from 25% down to about 10%. In fact, the DPP study was stopped a year early because it was so effective. So It's a very intensive lifestyle program. It's weekly meetings with a trained lifestyle coach, part of a support group. You do that for 6 months, and then there are monthly follow-ups after that. And our members have learned that it actually takes a lot of support to help patients stick with a program like that. So again, another reason to try to prioritize where you focus your efforts in getting people who are going to get the most benefit from that kind of a program. So the PCORI dissemination and implementation study was combining what was learned from the DPP data with longitudinal EHR data from about 50 million patients at Optum Labs, creating a predictive model that risk stratifies people with prediabetes and estimates benefit that they'll get from the DPP lifestyle program or taking metformin. The multivariate model is a much better predictor than any single clinical parameter because clinicians have several lab values available to them, like hemoglobin A1C or perhaps fasting plasma glucose, that indicated that the patient has prediabetes. But the other factors that you can bring into the model are a much better predictor all combined than any of those individual parameters. So those at high risk of progressing to diabetes are more likely to gain benefit, and those obviously at low risk are much less likely to benefit. Premier Medical Associates in Pittsburgh has been using this model for 9 months in their EHR. In that time, they've seen 670 high-risk patients with prediabetes. Before using the model, none of those patients had been referred to a diabetes prevention program, lifestyle program, even though Medicare is now willing to pay for that program, and metformin had been prescribed for just 6% of those people. Using the model, 44% were referred to the DPP lifestyle program, and nearly 20% were prescribed metformin. So action has been taken in 65% of high-risk people, 18% of those at moderate risk, and 4% of those at low risk. So it's just what you would want from a population health perspective. You're investing the intervention in the people who are most likely to benefit. We're currently turning this into a cloud-hosted predictive model using open EHR interoperability standards so that provider organizations can kind of subscribe. It's sort of like downloading an app to your smartphone, but downloading one to an EHR is a little more complicated than that. But the point is that the software development and testing and support can be done once rather than in every EHR around the country. So population health comes down to making the best decision for each individual patient, and this is just one of the tools that can enable that process to happen with a shared decision making between patient and clinician.
John, thank you. David.
Thanks, and I'd like to thank the Bipartisan Policy Center for inviting me here to share my thoughts with all of you this morning. The study that I'm going to briefly talk about was health homes for individuals living with persistent serious mental illness. And again, I oversee Pennsylvania Medicaid, and which includes our physical health as well as our behavioral health benefits. This particular study was conducted with the University of Pittsburgh as well as one of our behavioral health managed care plans, Community Care. And this was really focused on a very complex population that also is very costly in terms of medical costs. The intervention was quite interesting. It involved wellness coaching, self-directed management, a member registry, and the key component was care coordination, where in one arm there was embedded a nurse, usually a physical health nurse, into a community health, mental health center. And that team of care management, care coordination usually included peer specialists or targeted case managers. Again, the other arm of the study did not have the nurse involved, but there, all the other components were done. Some of the self-reported outcomes, and again, this is vitally important. Again, this is very person-focused. Was patient activation, functional status, quality of life, satisfaction with care, and status of mental health wellness. At the Department of Human Services, my agency, we decided to also work with Community Care because PCORI does not allow for economic analysis, but we wanted to actually look at these individuals that were in the study. From my standpoint, I have to go to my budgetary people and I have to justify programs. So we're actually able to look at the costs associated with these individuals versus a comparison group. So we were able to actually look at some of those outcomes. Some of the results that I thought were, well, actually were found to be statistically significant and I think clinically significant. Patients were much more activated in their health care. They understood their health care. Surprisingly, they were much more engaged, especially in primary care and specialty care on the physical health side. And their self-reported mental health status was improved. They also had a better understanding of their physical health as well as their mental health conditions, and especially, again, since this was delivered on the mental health clinics at the community level, the key part of the intervention was really bringing a touch of physical health integration into the care management module. And that care management team worked very closely with those individuals living with persistent serious mental illness. We also found that the medical cost spending went down by 15%. Preventative services went up, but so did physical health costs went up. However, those costs were offset by both behavioral health and physical health inpatient cost reductions. So overall, the costs actually were reduced for these individuals. So what have we done to actually disseminate this? That study started with, I believe, 11 sites. And we've continued to work with community care, behavioral health. Again, this is one of our managed care organizations. They have been able to disseminate this. And I will say the study actually occurred in both urban settings as well as rural settings. From those 11 sites, there are 61 provider organizations that are engaged in 23 counties throughout Pennsylvania, involving some very rural counties as well as some urban counties. But that also includes 40 adult community behavioral health centers, 10 adolescent centers, including 8 school-based sites, and 10 opioid treatment programs, and 7 residential treatment facilities for youth. So we've been able to disseminate this from that basic model into other settings as well. And we've gone from 11 to over 61 provider organizations. And again, currently they're focused on the adult population. They're focused on hypertension control as well as smoking cessation. And on the pediatric side, they're focused on looking at obesity. So again, we've been able to, working with community care and others, and our providers and the patients, we've been able to really widely disseminate this model of care across Pennsylvania for our Medicaid recipients, again, for those individuals living with persistent mental illness.
Wonderful. David, I just would love for you to paint a little bit of a picture, because I think that often people use phrases like a complex, costly population. Really describe these individuals for us in a way that a layperson like me can understand what we're really talking about here.
Again, these are individuals that have severe mental health conditions. Many times, again, persistent, so for many years. They struggle with many of the social determinants of health: food insecurity, housing insecurity, transportation. So some of they're more worried about their very basic needs versus their medical care. And many of them, again, one of the things we're focused on is smoking cessation, because tobacco companies actually target this population to increase their sales. So these are individuals that, from a Medicaid standpoint, are costly. They also, a very high percentage of them, also have substance use disorder. So again, that makes it even more complex in getting them into treatment, keeping them in treatment and being adherent to treatment. So again, one of the neat things about this program is it really got folks motivated, engaged in their treatment, and they had a better understanding of what was going on with their lives.
Super. And John Bolger, let's come back to, I appreciate you kind of gave the big picture of many of those ACHP case studies, but I do want to come back to Geisinger's because it is one of my favorites. And Hep C, pretty interesting developments a few years ago in terms of therapy for Hep C. So give us a little bit more of the storyline there. Sure.
So hepatitis C is a chronic disease caused by a virus that attacks people's liver. And as Cece was saying, a few years ago, there were treatments before. There were drugs that could treat the Hep C but weren't necessarily curative and were difficult for patients to take sometimes, and it was considered a chronic disease. What happened several years ago was there was a new class of drugs which have since been continued to be perfected that actually can cure hepatitis C. So long-standing hepatitis C ended up progressing to liver failure. Sometimes those people would get liver transplants, but it was a kind of a long-term chronic disease as the question Cece just asked. Now those drugs came on the market, you can actually cure the disease. A couple caveats though are, one, you need to take 8 to 12 weeks of therapy to get the cure. If you stop the drugs within the 8 to 12 weeks, you don't get the cure and you have to start all over again. So it's not like you had 4 weeks in and it's an 8-week treatment and I've stopped them and then I want to come back 6 months later and start them again. You have to start over. And the other thing which got a lot of press was the drugs were very expensive. So a 4-week treatment could be $30,000, $40,000, $60,000 for the treatment, and you think, well, now I need 12 weeks of treatment, and you end up doing the math, and that you spend that money for that drug and you stop it and you didn't get the cure. So really what we were looking at was, how do you improve the cure rates? How do you get the people that are taking the drug to be the right people to take the drug and that it's going to cure them? How do you make sure they're going to take the entire course of the treatment, because that's what they need to get the cure? And understanding that many of the people in this population are in the population that Dave was talking about. Most of the members we are treating at Geisinger are in Pennsylvania Medicaid. So there's a lot of social determinants of health and other things. The reason many times they're not taking the full course is not because they don't want to take the full course. It's because they can't get the drug, they can't get transportation to the pharmacy to get the drug, they can't get to their doctor. They're more worried about putting food on the table than they are getting the drug and what the cost of the drug is. So by putting the process into place, we were aiming to combat all that. What we've seen is the cure rate at baseline, and even some of the national cure rates, are in the high 80, low 90%. We are actually at a 99+% cure rate now at Geisinger with those treatments. The other thing we've seen is that from a cost of care standpoint, by looking at the data and iterating in real time, so new drugs keep coming out. Some of those drugs are less expensive than the older drugs, but are actually more effective than the older drugs. Some of the patients actually don't need to be treated for 12 weeks. They can be treated for 8 weeks. And when the drug costs $30,000 for 4 weeks treatment, taking 4 weeks out of the treatment and getting the same outcome is huge. In fact, you know, one of the things, and this was a light bulb moment for one of our specialists, I still keep the email, and he said to me, he said, it was kind of aha, if I use the right drug and treat that patient for 8 weeks, every 2 people I treated, so it was 90,000, now it's 60,000, the third patient's free. And you know, that was one of these things where, and we talked, the question I think that was in the earlier session was, you know, how do you sometimes get physicians to change their behavior? Most of the time is showing them data like that, and they get it. And they get that that has impact on their patients too, because patients that are in a cost share situation, that's a third of the cost share for the patients, and it's more likely that they're actually going to take it and get the treatment. But by putting that piece in place where you have the teamwork, you have a pharmacist leading the team, you have a group that's keeping track of this, we're making sure every patient gets the right drug, gets the most cost-effective drug they can, and then gets the follow-up they need, whatever that happens to be, to make sure they take the whole drug. So that's really has been the big win around that program.
Wonderful. Each of you have spoken, obviously, about data transparency, data interoperability. But I'm going to flip that around a little bit, and maybe, John, I'll start with you, given your informatics expertise. There's so much data out there now. How do we sift through, and what do you do when you come across useless data, irrelevant data? How do you kind of move people off of that and keep them focused on the meaningful data? Can you give us an example?
Well, I think the most meaningful data are those that are customized to an individual patient. So where we can use data, and this is where the longitudinal data that we're now accumulating with all of the EHRs that are capturing those data, we get this longitudinal data as a byproduct of care, and we're able to use it, I think, to help guide a decision-making process with individual patients. So good example of using data, PCORI, and I've become a real believer in doing patient focus groups as part of every study and having patients on the team, because as we were starting this work on predictive modeling and using predictive models for shared decision making with patients, there was a question, well, are patients really going to be able to understand these probabilities that we are computing? And the striking finding from our focus group with the patients was, who had prediabetes, every one of them was able to quote the ages at which 4 or 5 family members developed type 2 diabetes. And I thought that was they were already working with numbers. They just weren't numbers that were necessarily personalized to them. But there was a risk concept there, and there was a probability concept. So I think it gave us a lot of confidence that if we can build a model that is personalized for an individual, that there's a real opportunity to get that used, get people to understand the information. One of the providers who's been very effective in getting folks to actually follow through with the DPP lifestyle program says it's really helpful, and not in a threatening way, but just to say there's a 50-50 chance that I'll be telling you 3 years from now that you have diabetes. There's an intervention that can cut that risk in half. And that concept and that way of presenting data, similar to the excellent graphics that are used in the chest pain outcome example. You know, those are the things that I think we need to work on to make the data more useful and to make it customized to an individual patient's not only clinical condition, but also what they're interested in and what they want to achieve.
I do want to ask about scale and spread, and I'd love for each of you to weigh in, because I think in each of your case studies, we see the ability to scale or spread interventions or models or approaches or strategies. And so, David, if we start with you, and going from 11 to 61 is really just sort of mind-boggling, to tell you the truth, especially with that patient population. Each of you talk a little bit about, once you get to that moment where you want to scale or spread or adopt the model, what are the challenges? What do you think through to make that next leap?
So again, having some of the cost data was helpful for us because it really justified the program, and the behavioral health managed care plan understood their financials. We also provided physical health financials. That nurse was quickly paid for. So it made the dissemination, at least within that managed care plan and within those providers, within those communities, it really got them to see the light. So from a policy standpoint, though, having that information about the clinical effectiveness and the patient engagement and the motivation in this population really allowed, us as a program to say this is something we should disseminate. And we have several mechanisms that we can use to disseminate policies, and John knows many of them. One of them is in our contracts with our managed care plans. So while we've not mandated this on the behavioral health side, we have put into place some similar programs on the physical health side. So we can actually use contract language with our managed care plans to even more widely disseminate these types of programs.
So that is a handy lever that you have. It is. But used wisely. John, talk about spread, taking concepts to scale.
I think 2 points. One, agree certainly on the economics. That's a really important consideration. So Intermountain Health Plan has published the finding that for every person in whom the onset of type 2 diabetes is prevented or delayed, the health plan saves $3,500 per year. So delaying by 5 years, $17,500. So you can begin to, if you can, investing the effort to get people to actually stay with the DPP lifestyle program, certainly worthwhile. So I think that's really important. I think the other thing is just practically delivering these multivariable predictive models at the point of care in the EHR is an important part of this. And PCORI is in the process of considering supplemental funding to enable us to build a cloud-hosted predictive model so that the EHRs can subscribe to it. And I think that's a really important thing, because what we found is that if people have to build these complicated models into their own EHRs and validate them and test them and maintain them and do all of that work, it's just way too much work. So I think the idea of being able to have something that's available using the EHR standards that the Office of the National Coordinator and CMS are now pushing, and all of the vendors are adopting, the EHR vendors are adopting, and most organizations are beginning to get some experience with. I think it makes it a lot easier. We have had, in one of our members, we have had people using the model where they actually had to enter the data by hand. And there are 11 variables in the model. And it's much easier if you can use these standards, expose the variables to the cloud-hosted model, and actually collect the data automatically and return the estimate of risk to the patient and the clinician.
And thank you, probably without realizing it, you gave another plug to an ACHP member, Intermountain and Select Health. And I think for anybody who gets the chance to go to Salt Lake and see what's going on there, they really are an organization that right now is on the cutting edge of leveraging a plan and a provider entity with local community to tackle some of these very complex challenges in our society today. John, if I'm not mistaken, you were able to take your experience and model from Hep C and start to take it over into other challenges. Is that correct?
Yes, we were. And Select Health was part of the dissemination project we worked on. They were the early elected deliveries piece of that. But we've been able to spread the Hep C across the system. So we started with one site, what we called Center of Excellence, and spread that across the Geisinger system. And then we also spread it to other non-Geisinger entities that we've worked with. But the other thing, as Cece said, is we've taken the model, that consensus, teamwork, education, getting the data, and then aligning the incentives, and put that into play with a bunch of other things. So multiple sclerosis is one of those. Macular degeneration, psoriasis, diabetes. So taking that same model and spreading it to other things. And what you find out is it's not one size fits all, which is why that implementation science is important, why going through the steps many times is important, because how you would implement even hepatitis C in one organization or one system is going to be a little different than you do in another system. But you can do it across anything. I think having an electronic health record is a huge help, but as John noted, you can do this in paper. This isn't something that you need the bright, shiny object to be able to make this work, but you do need people working together to make it work. We did this with psoriasis, and the difference was whether to use a biologic drug versus using light box therapy. And as you can imagine, the biologic drug is thousands of dollars, and the light box therapy is hundreds of dollars. But as you go through the process, you realize, and this is, again, why it's important to have patients involved. When we started it, when you looked at it from a patient view, they actually paid more for the light box, which was hundreds of dollars to the healthcare system, versus the drug, which was thousands of dollars to the healthcare system because of the way copays and their insurance work. So changing that around and working with patients, because they said, hey, sure, you know, looks like it's saving money in the system, but it's costing me more money. It's easier for me to go get the drug in my doctor's office or an infusion center. So, you know, that's one example of, you know, having to understand the whole picture in totality and be real holistic about what you're doing and go through those steps as you're spreading it. But I believe it's that process is completely adaptable to a whole bunch of different places and environments to make it work.
Mm-hmm. And I recall well why PCORI does not get into economic evaluation, having been there here for that debate. But I appreciate that our panelists are bringing that into this conversation. My own personal opinion is it has to be a part of any healthcare dialogue in 2019. And what you're also hearing here is that these leaders are aware of healthcare affordability from all of the different perspectives, right? So hearing about from a patient perspective, if it's your copay or your deductible, if it's the state taxpayer, you know, state and federal government, those are your taxes. It may be squeezing out other priorities that the state of Pennsylvania might have. And, you know, the same with the physician groups in terms of the easier that you can make it for them, the more affordable, you know, for their practice. So I really appreciate that from this group. Our little flashing sign tells me that we have time for some questions. Yes, please.
Hi, I'm Christina Nyquist, and I come from an Italian family too.
We're going to give you a microphone.
Oh,
Christina.
okay. I'll be traditional and use the microphone. I have a two-part question. The first is, when you are deciding on best practices, do you ever look at NICE reports coming out of the United Kingdom, and does that have any influence? And second, the FDA is starting to clear digital therapies, and I'm wondering if that is being factored into any future assessments.
Great. Anybody going to confess to looking at NICE?
You know, we look as broadly as we can, and we have looked. Actually, my son's in college in Liverpool, so I'm back and forth to England quite a bit. But we cast a very broad net when we're looking at best evidence. And, you know, I think that's an important piece because, as you said, there are people that have figured this out, and a lot of this stuff we talk about it being innovation, but really it's imitation, and that's okay. I mean, the whole goal of getting from 17 years to 1 year is really sharing with each other and understanding what other people are doing. So we do cast a broad net, and we've looked in other countries, we've looked, you know, in databases and different places. The clearinghouse that existed, we use that a lot, and you know, all those sources are important. On the digital, you know, we've looked at places where we can supplement a lot of things. So in diabetes, in COPD, in a bunch of different places where we're actually using now digital tools to supplement the things we're doing. Some of those are apps that are giving us patient-reported outcomes in the apps, and then those patient-reported outcomes then trigger something. It's a lot of that in chronic disease, heart failure, COPD, diabetes, but other places where you can use behavioral therapy, and I'm sure Dave has some comments, on depression and smoking cessation. There are places where we're using digital tools in that space as well, and they're very helpful, and something that, they're not for everybody, different, and this is where you get the personalized, some patients that's helpful, some patients it's not. So the more tools you can bring, I think, to your armamentarium, the more likely you are to make change.
Mm-hmm. And we have looked at nice guidelines for each of our collaboratives and campaigns that our foundation runs. So it's actually been very helpful because they're really quite practical in their focus. In terms of digital outreach, obviously telehealth is becoming more important in general. I know you're thinking probably of something that's a little more personal interaction with the patient. But one of the examples that, we have learned about is people in rural areas, the Billings Clinic in Billings, Montana, where they have outlying clinics that are really quite far away. They're actually delivering the diabetes prevention program partially electronically. So that's an example of use of that technology.
That's great. David, anything to add?
And again, in the Medicaid program, we encourage our managed care plans to use a whole host of platforms, including telemedicine. We're really interested in MAT delivery using telemedicine. On the behavioral health side, we pay for telemedicine, and it really helps with access to care, especially in some of our rural counties. We also have other programs where we do telephonic consultation to providers for children for pediatric behavioral health concerns. So we are really encouraging our managed care plans to use a whole host of digital applications, and they can subcontract with companies that can be very innovative.
Did I see another hand? Yeah.
Bill Signer. This has been a great discussion. You talked a lot about best practices, models, patient-specific data. My question is, how often are you seeing medical advertising interfering with or influencing what a patient decides, as opposed to your own models that you're telling them what is the best way to treat a patient?
Yeah, that's a great question. I mean, I think that's part of the education piece that we saw specifically with hepatitis C, because when there's a lot of advertising on the drugs for hepatitis C, and the psoriasis example I gave, there's a lot of advertising in that space as well. So I think that is just a piece of our education. You do have patients coming in asking specific questions from what they see in that advertising, and it's really, getting into a shared decision-making conversation and laying out all the facts for them, because I think the worst thing you can do is shut down what they're bringing in when they come in and say, well, no, don't ignore that, we do what I want to do, because you end up not being as likely to get the outcome you want to get from that. So I think we try to embrace that and understand what's out there, and also use that as part of the education when we're talking to patients.
Good.
I would just comment that if DPP was marketed the way the psoriasis drugs are marketed, think of the improved patient outcomes and the cost savings that would be generated in a program that now, was proven 17 years ago to be very effective. So think about that.
Good point.
Is there one last question? Final couple minutes. Okay, then I am going to first thank Bill Hoagland and the Bipartisan Policy Center and PCORI for the support of this type of research, this wonderful event this morning, and please join me in thanking our panelists.
2.5 hours. Thanks to the moderators, the panelists. Cece mentioned ACHP and PCORI for their tremendous input here and partnership, and we look forward to continuing these discussions with all of you moving forward. It's a critical issue. I think, as Bill mentioned earlier, just like there's bipartisan support and interest for biomedical research, there really needs to be the same for patient-centered comparative effectiveness research. So thanks everybody. Thanks for joining us today, and looking forward to continuing the conversation. Thank you.